Hello, everyone, and welcome to our live session today. I will be going over a quick startup presentation to welcome you all and introduce you to our program and the various opportunities we offer if you have, of course, not previously attended any of our shadowing sessions. I do want to highlight that Pre-Health Shadowing is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources no matter their demographic status, abilities, or location. My name is Jesus. I am the Chief of Program Planning here at PHS, and I want to thank you all for attending today. Now, let's get started. Just a little PSA, we do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your Zoom screen. And if you need assistance in labeling the transcript, please direct message one of our team members. We are always looking for ways to be more inclusive and ensure our sessions are accessible to everyone. So please, if you have any recommendations whatsoever for how we can improve, you can definitely email us at info@prehealthshadowing.com. So since this is an international program, we do want to know, where are you guys Zooming from today? You can drop it in the chat to let us know. Okay, oh, the Middle East. Oh, wonderful, New Jersey. Thank you guys so much, China. Oh, that's wonderful. We have people from all over. Thank you guys so much. I myself am calling in from the beautiful island of Puerto Rico and the Caribbean. If you want to stay in the loop, you can follow us on social media. We are active on both Instagram and TikTok, or you can also sign up for our email list on our website to never miss a session. And we do have some wonderful opportunities for you all as benefits of being a part of our program. And if you were by any chance looking to get research experience, I am very excited to announce that Pre-Health Shadowing is launching a research program that will allow students to connect with principal investigators as they conduct research in a plethora of topics, fields, and locations. This program is 100% remote, which means you have the power to connect with absolutely anyone. For more information, you can fill out the interest form that was sent in the chat below, and we will get back to you as soon as possible with any additional details we may have. We have partnered up with Kaplan to get our students a 10% discount code that can be used on all Kaplan products, as well as free resources such as study guides to help you prepare for your standardized tests like the MCAT, the NCLEX, or the PCAT. If you fill out our short survey in the chat, we will get you signed up for these deals for free. And I would also like to draw your attention to another amazing program, that being Neolith. Neolith is an online mental health platform for students. For pre-health professionals especially, we know the path isn't easy, so that is why we have partnered with Neolith to spread the word and offer free access to their services if you use the link in the chat or enter the code PREHEALTH when signing up. Additionally, we are really excited to announce that we have partnered up with Krispy Kreme for you to purchase one delicious dozen donuts to enjoy with your loved ones. With a donation of $10, you'll be able to receive your treat while also helping us here at PHS. More information and instructions can be found by clicking the link that was sent in the chat. Mask for Mask is another amazing women-led organization that donates 4 masks for every 4 masks sold. These go to people in need during the COVID-19 pandemic, those in the homeless community, healthcare workers without their proper PPE, and others who are struggling to stay safe. With our discount code PHS15, you can get 15% off your order. And if you buy through this method, Pre-Health Shadowing will also get 10% of the proceeds, which is amazing because, as I mentioned earlier, we are a nonprofit that runs solely off of the support of our community. If by any chance you want to play a bigger part in supporting PHS, we would love for you to join our network of student volunteers and team members. You can apply to be part of our administrative team and lead students in various projects and initiatives with professional outreach, grant writing, and a lot more. We understand, of course, that as a pre-health student, you may not have the time. So we also offer the opportunity to volunteer asynchronously with tasks that can be done on your own time. We would definitely love to have you be part of this program and contribute your own unique perspective. Also, wonderful news. If you are a high school student and you want to get involved, we have started a program called HTP, or High School Training for PHS, which allows you to connect with college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students that are interested in medicine through pre-health shadowing. Here at PHS, we do want to recognize the hard work of all of our students in the program. So if you are interested in getting published, you can submit essays, reflections, research papers, and reviews to our editor-in-chief through the link dropped in the chat to have your work on our website. This will look great on CVs, applications, resumes, etc. So do take advantage of this. Part of our mission at PHS is to promote diversity. And in order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these upcoming events include a series on patient experiences, a COVID-19 roundtable, and an international student forum. If you have a mentor, professor, or professional that has inspired you in any way, and you think they could contribute to these conversations, please nominate them today using the link in the chat. If you can, we humbly ask that you donate to our program. As you know, pre-health shadowing is completely student-run, and we are working around the clock to keep this free and accessible to everyone. Unfortunately, Zoom and our website are not free, so any contribution you can give would be greatly appreciated. Of course, if you are not financially able, we request you send this link to someone you think can, so we can continue to support those who cannot afford similar opportunities. Throughout this session today, we encourage you all to drop any questions you may have for the speaker in the chat, and our team members will be making note of these to be asked in the latter half of the session, that being the Q&A session. Also, I want to encourage you all to take really good notes as our professional is going over their presentation, as there will be the chance to take a post-shadowing assessment to verify your virtual shadowing hours. More information will be available on this at the end of the session, so stay tuned. Lastly, if you can, we request you turn your cameras on. This is by no means an obligation, as we are respectful of different circumstances, but it does help us feel closer together in a time when socially distancing is mandatory. We also request that you make sure to mute yourself, as this will ensure the professional has the complete and full attention from the audience. Once again, I appreciate you all for listening, and now I would like to welcome our professional, Dr. Parisis. Thank you so much for joining us today. You may share your screen whenever you are ready.
All right, well, thanks for having me. It's very flattering. I'm going to go ahead and share right now, and I guess let's jump into things. So my name is Nick. I'm a radiology resident. I just finished my first year of residency, and I'm no longer an intern, and I'll be starting PGY2, or post-grad year 2 of residency, which from here on out will be completely radiology. So today we'll be talking about the specialty of radiology, many of the reasons why I decided to go into radiology. We'll also talk about artificial intelligence, a little bit about myself, of course, and basically the latter half of this presentation will be clinical cases, anatomy, imaging, x-rays, stuff like that. And then we'll stop at points, so once kind of halfway through, and then once at the end to take any questions. So there's lots of information in here, so Before we get started, feel free to follow me on Instagram and TikTok, just Dr. Parisis. And please, I encourage you to stay connected in any way that's most convenient to you. So I am from a small town in Northern California, about 2 hours from the San Francisco Bay Area, or about 45 minutes from Sacramento. And then I attended the University of California, Santa Cruz. Santa Cruz is about 2 hours south from San Francisco, small little beach town. And that's where I majored in molecular, cell, and developmental biology. And while I was at Santa Cruz, I also played D1 rugby for all 4 years. So it's a little bit about myself. And after that, I took 2 gap years. So in those 2 gap years, I basically got my life together, figured out that I wanted to do medicine, and got my letters of application in line, your personal statement, transcript. You write all your little essays for all your extracurriculars. Basically got my stuff in line. And I also worked at a Google Glass startup called Augmetics in San Francisco, where we basically did remote scribing for physicians. So in that time, I basically applied to med school, applied to about 30 schools, and then I ended up attending the Lake Erie College of Osteopathic Medicine in Bradenton, Florida. Bradenton is near Sarasota or the Tampa Bay area, and I did my first and second year of medical school there, so kind of the preclinical or kind of the bookwork part of med school. And then I decided to go to LECOM Bradenton because they had a clinical rotation site in San Diego, actually. So I actually moved back to San Diego for third and fourth year of medical school. And then I matched at the University of Minnesota in Minneapolis for radiology. So it's a little bit about myself. I have some of my hobbies listed here for you guys. And yeah, social media in the past year has kind of been a kind of new hobby. In addition to kind of sports growing up, I did rugby in college and wrestling in high school. I also played traditional Greek folk music, and I posted a little bit about these hobbies on Instagram if you guys want to check that out. So medical school is kind of like drinking from a fire hydrant because there is so much information coming at you that the only way to manage it is by coming in from the side, just like this guy is, and taking little sips. So you have to really you got to tame the beast. You got to manage it. This is the only way to do it. And people have done it before me. People will do it after me, and people will do it, before and after you as well. So don't feel discouraged. Another nice metaphor is this meme here, where medical school is kind of like eating a stack of pancakes every day for breakfast, lunch, and dinner. So the stuff that you're learning in med school is super cool. All the science, the mechanism of disease, the pharmacology, the physiology and anatomy, it's all really, really engaging. So this is the analogy to a stack of pancakes. We all like 3 pancakes with syrup and butter on like a Saturday, a Saturday morning brunch, but it's kind of like having to do that like every day. Like it's just a grind, right? So I thought this was quite a nice metaphor for that as well. There are a lot of misconceptions about what a radiologist is. Are they a physician or not? They are physicians. What do they do? Do they take x-rays? Do they read x-rays? They don't take x-rays. So some people think we just talk into a microphone all day long. We do some kind of minimally invasive procedures, so kind of surgery light. Some people think we play video games if they're children. I don't know what they think. And basically, this is so we'll address some of these misconceptions throughout this presentation. Basically, this is a picture of the very, very first x-ray taken over 120 years ago. This guy's name, I think, is Wilhelm Röntgen. He's German, and this is a picture of his wife here. This is his wife's hand. This is her wedding ring, actually. So you'll kind of compare this fuzzy x-ray picture to the x-rays that we currently have and the technology that we currently have. About 3 weeks later, he actually took a picture of his best friend's hand. So this is not his wife's hand. This is his friend's hand with his ring on his hand. So these are some of the very first x-rays ever taken. So we started out with x-rays over 100 years ago, like I said. Then we had ultrasound, which uses sound waves. They're also called sonograms. X-rays are also called radiographs. So we have radiographs, ultrasounds, then we have CT scans. And this is kind of like a very, very advanced x-ray. Then we have MRIs, or magnetic resonance imaging. So M stands for magnet. So it's this huge magnet that basically aligns all the water molecules in your body and then allows you to see the different tissues in the body. Then this is kind of the evolution of radiology. So then you had kind of transcriptionists, and then everyone in the emergency department is using CT scans all the time, and then people forget how to examine a patient. And then, we'll see kind of where things end up with artificial intelligence. Some people think that AI will replace the radiologist, and we'll also talk about that at the very end of this, or towards the end of this. So why? A few more things about the specialty of radiology. So this is kind of what a diagnostic radiologist workstation kind of looks like. There's typically 4 or 5 large computer screens. They're like 6K or 8K resolution. They cost like as much as a small car might, anywhere from $10,000 to $20,000 each. And they have super high resolution. And basically, the radiologist sits at this workstation. They could stand if they like. It's a standing desk. And then they dictate into a dictaphone that has software that picks up the medical jargon that we use. And then we create a radiology report. So this report gets sent out into the electronic medical record, and other surgeons, clinicians, internal medicine doctors, primary care doctors can see this report and see the results of what the patient's anatomy was or what their disease process is. And then they use that as an objective data point to make decisions about patient care. So basically, sometimes you can't always figure everything out by talking to the patient and physically examining them. So sometimes you need to take a look into the body, into the anatomy. And so radiology is kind of the eye of medicine. So these are some of the technologies that we have, or the imaging modalities that we have to image the body. We have X-rays, CT scans, ultrasounds, MRIs. We also have something called nuclear studies, where we use radioactive isotopes to look at the physiology in real time. Then we also have fluoroscopy, which is kind of like live X-ray. So fluoroscopy is typically used to do procedures. Ultrasound is also used to help guide procedural work. So in short, basically the radiologist focuses on actually making diagnoses, like making hard calls about what the diagnosis is, but also we do procedures to help treat disease. And we also do take care of some patients. So our role is basically to help guide the clinician and guide the surgeons. Like, are we going to treat this patient with surgery, or are they a non-operative candidate? Are we going to treat them with this chemotherapy or that chemotherapy, et cetera, and so on? Like, is this going to be conservative management or medical management? So radiologists do a bunch of different procedures. I'll talk about some of these in some slides up ahead. We also, depending on what fellowship that you're trained in, we do also take care of a good amount of patients. So some fellowships, like breast imaging and interventional radiology, those fellowship trained radiologists, they actually have clinic once a week or once a week for like a half day. So they see a good amount of patients. This is different from maybe the more diagnostic aspect of the work, which is a little bit more removed from direct patient care. Of course, we still see patients when we do our procedures, so they're not, completely removed from patient care. Another thing that we do in radiology is called protocoling. So protocoling is basically like, maybe you're Dr. Smith or something, and he's calling you to ask like how to order a certain study. Like, do I order it with contrast or without contrast? Am I imaging the right part of the body? Is there a better study to kind of visualize what I am looking for in this patient? So that's called protocoling, because we can help guide the clinician in how to order a certain study. They say something like 40% of all radiology imaging studies are like ordered incorrectly. So that's also part of our job. Another part of our job is actually treating patients with medication in case they have what's called a contrast reaction. So you typically give contrast like intravenously, or there's also like PO or oral contrast. And sometimes patients can have contrast reactions. So we can treat them with steroids or with Benadryl. And basically contrast helps us see different parts of the body better. We also interact a good amount with the radiology technologists. These are the people who are actually acquiring the images. They're actually putting the patient into the CT scanner or bringing the X-ray machine to the patient and like getting the image. So oftentimes they have questions or they have information in their report that is useful for our report. And so we'll talk a lot throughout the day. In radiology residency, we also learn about radiation safety. So just for some context and perspective, flying from San Francisco to New York City, that gives you as much radiation as a chest X-ray does. So there is always going to be some baseline radiation that we're all exposed to, right? Because after all, the sun is beaming on us with ultraviolet radiation. So, and then if you're flying, of course, that might be a little bit more because you're closer to the sun, you're further off of, where the Earth's surface is, of course. And then a CT scan, just for reference, depending on which part of the body is imaged, a CT scan can have 10 or 20 or 10 or 100 or even 1,000 times more radiation than an X-ray would. So in the type of radiation that I'm talking about, it's important to know that this is ionizing radiation. So ionizing radiation can cause cancer down the line because it can cause DNA mutations. So this is in contrast to non-ionizing radiation. So X-ray and CT, they have ionizing radiation. Ultrasound and MRI, they have non-ionizing radiation. Remember, MRI uses magnets, and then ultrasound uses sound waves. So hope that's helpful for you guys. Okay, here's a cartoon of this kid's dad basically saying, you're never going to amount to anything staring at that screen all day long. And here the kid is, playing their video games. And radiology is as close to a tech job or a computer job as you can get. So here he is saying, I'm glad you made something out of yourself and stopped staring at this screen, but now you're staring at a different screen. So I think this is a positive aspect. You may not necessarily agree with me, but that's okay. But I think this is pretty cool. So it's as close to a computer or desk job as you can get. And if you can imagine, there's kind of a large radiology reading room where there's anywhere from 3 or 4 up to maybe like 6 or 7 workstations with those big computer setups and like a nice standing desk and like your little dictaphone where you can, like a microphone where you can speak into. And the lights are dimmed a little bit, so it's a little bit dark. And the reason for that is in order for our eye to kind of perceive more light coming from the screen. So it helps improve our acumen or our accuracy in like actually reading the images. So this is the radiologist at night, and it's dark, of course, and then the radiologist during the day. It's not completely pitch black, but it is a little bit more dim. And there's good reason for this. This is kind of what the day in the life of a radiologist might look like. Throughout the day, of course, you're doing your regular stuff, breakfast, lunch, dinner, drive to work, drive back to work. But if you can imagine kind of your day of doing this diagnostic work, basically reading images and interpreting them and giving a report, the day is kind of broken up by doing things like procedures, doing things like talking to a patient and consenting them, like, hey, these are the risks and benefits of the procedure. And then talking, asking if they have any questions. You also spend time protocoling, like I talked about earlier. If you're an attending, you might be doing spending some time teaching, like a resident, or even like typically at lunch, there's like a conference or like a lecture. So if you're an attending, you might just go through some cases for like 30 minutes or 45 minutes and do some teaching. So you also spend a good amount of time on the phone because oftentimes other doctors will call you if they have questions about the imaging for their patient. Oftentimes they may not call you and they might just come into the door and then come in with like the whole team, and then you'll pull up the images and you'll chat for like 10 or 15 minutes about whatever questions that they had. So I think it's pretty nice. It's like quite nice and collaborative in that way. If you have a academic day in your, let's say, 5-day work week, you might spend one day doing things like research or mentorship or basically like helping guide or mentor like a medical student or a resident. And then, you might spend some time in clinic. So let's say your morning might have like clinic for mammography patients or, potentially breast cancer patients. And then you'll spend like basically your 8 to 5 talking to them, and then spending like an hour at a time, like consenting them, and then doing the procedure, for example. If you're an interventional radiologist, you might spend like an entire day at clinic or an entire half day just seeing patients and talking to them about the procedures or like the services that you have to offer. So that's kind of what a day in the life kind of looks like. This is kind of what a day in the life kind of looks like for a kind of general medical doctor. Oftentimes we have this image in our mind that there's a lot of patient care, but oftentimes we are stuck at the computer, just like the radiologist. Everyone spends time at the computer these days. So for me, I was like, if I'm going to spend time at the computer, I'd like for it to be quite a nice setup. So a lot of your time is spent entering things into the computer to satisfy insurance companies, billing things, things that are not directly interesting to the medical doctor. So then there's, time that's lost when you're waiting for scans to be done, waiting for lab work or following up on these things. Patients need to be transferred oftentimes from different floors of the hospital. You might be waiting for like recommendations from a consultant, et cetera, and so on. So radiology is nice because you spend less time doing these things and more time actually doing direct kind of medical, or like directly doing medicine, or like interpreting studies, or like just doing procedures and talking to patients. So I think this survey from Medscape kind of illustrates that point quite nicely, because these are the hours per week that a radiologist might spend on paperwork and administration. So I think we do pretty good in this aspect if you do not enjoy these things, which I found for myself that I definitely did not. So you can see some of the specialties that land a little higher on this score. So why radiology? So quite a few reasons. So I talked about, so there is basically the first reason, the most important reason for me, is that the imaging that is done on a patient, it has a direct impact on patient outcomes. So think about it this way, like the x-ray that you read, that is a metric, just like lab work or an EKG would be in like the emergency department. That is one piece of data that is very important. It's very pivotal in like what is going to happen to this patient. Are they going to go into the hospital, or are they going to go home and follow up with their primary care doctor? So the imaging has a direct impact on patient outcomes. Plus, if you think about it this way, from even a public health perspective, you could, let's say, read anywhere from 100 to 200 studies in a day. This is a combination of X-rays, CT scans, MRIs, and let's say mammograms and ultrasounds. Let's say it's like 120 or something. Then that means that you basically have had an impact on 120 people that day. So I think that's pretty cool too. This is in contrast to like primary care, where like you're in clinic, let's say, and you see like 30 patients in a day, which is still very, very busy, right? Also, like if you're a surgeon, like how many surgeries can you really do in a day? I don't think it's like 100, but you know what I mean? So the impact is like pretty big, which is pretty cool. I talked about this on the slide before. There is not so much paperwork and bureaucracy, so we kind of focus on looking for anatomic pathology, or like looking for a disease in the image. So we're not spending that much time doing things like placing orders, doing chart review, talking to insurance companies or the pharmacy, or figuring out like where is this patient going to go after the hospitalization, like disposition, and coordinating their kind of social aspects of health. So of course, social determinants of health are extremely important, but I was more interested in the medicine side of things. So another reason why I chose it was because radiology is very broad and diverse, and there's so much variety. So we cover every organ system from head to toe, and we cover it in quite a lot of detail. So I think that's pretty cool, because radiology has its hands into like almost every medical specialty that I can think of, with the exception of maybe psychiatry. They probably have the least imaging ordered of all medical specialties. So some of the rarest diagnoses often require imaging to make them. So that makes, I think, radiology for a very interesting specialty. We also take care of some very sick and very acutely complex patients. So I think this is nice because we can have a big impact on these very sick patients. But again, it also makes it for a very interesting specialty, because there's a lot of things that can be going on. I also think that radiology in general is kind of an innovative and cutting edge specialty. Of course, now we have artificial intelligence as a tool that will basically change the way that we are practicing radiology in like 20 or 30 years. And I found that the specialty in general, like people generally enjoy teaching, they enjoy doing research, not everyone, of course. And because of this big emphasis on kind of teaching and knowledge, there is a huge emphasis on studying during residency as well. So the radiologist has to know a ton. So if you enjoy being very knowledgeable, I think this is pretty cool. I enjoy this part of radiology. Of course, the studying never ends. So in any specialty, the studying never ends. So of course, trying to fit in a couple of weeks of or fit in like a whole semester's worth of studying, you can't cram this stuff, right? There's a reason why you have to do 4 years of undergrad and 4 years of med school, and then a year of internship or an intern year, even before you even get to radiology, because all of that knowledge that you've accumulated is kind of a prerequisite to even understanding like kind of what's theoretically going on, what's clinically going on, like in real life, what's the real life importance of all of these things that I learned in like physics and undergrad and in my internal medicine rotations during medical school or my surgery rotations. So the knowledge will come kind of through osmosis as you go through residency. So if you ask, if you poll a bunch of radiologists and you ask them, would I choose the same specialty? I think we do pretty good over here. 93% say that they would. I think this is certainly something to think about if career longevity is a factor in anyone deciding on a specialty. You want to think like, am I going to be burned out when I'm 50 or 60, or if I'm 65, like, can I work another 5 or 10 years if I need to save more for retirement? I mean, we're all kind of working more for less, and we have things like student loans. Burnout is super high. Physician suicide is like double the rate of the baseline population. So there's a lot of things to think about. Of course, medicine isn't all, super glamorous, and it's also not super negative all the time, like I'm describing, but you also want to pick a specialty where people are generally happy with their decision. This is another poll from 2018, again from Medscape, just kind of depicted a little bit differently here. Here you can see the physician pain scale. Up here we have in the blue, living the dream. And I think radiology, again, does pretty good up here with other specialties like orthopedics, plastic surgery, dermatology, et cetera, and so on. So feel free to screenshot any of this stuff along the way if this is interesting to you. So why radiology? So I noticed that people switch over into radiology from other specialties. So when I was interviewing for residency about 1.5 years ago, I noticed that people were on the interview trail who were already in residency, and they were taking time away from their residency to try and land a radiology residency. So I was like, oh, wow, that's interesting. And I also noticed that once people got to radiology, they generally don't leave the specialty. So I think I know maybe one person where they are leaving the specialty. So it's very, very uncommon. And when you're in med school, you want to think like, am I more of a thinker or am I more of a doer? Like, do I want to work with my hands more, or am I more of like do I want to do more like mental work, like with my mind? So I think radiology is cool because we have a very cerebral workflow. So of course, reading images is very taxing on the mind. It can be very exhausting at the end of the day. But we also break up the day with working with our hands. And if you want to primarily work with your hands, then you definitely can do that with interventional radiology and breast imaging. They offer so many procedures throughout the day. So if you basically what I'm saying is like you can do both of these things and kind of toggle how much you want the thinking versus doing aspects of medicine. So I thought that was pretty cool too. I think the reading room, it's a little bit dimmer. I think it's generally a lower stress place. It's generally not as noisy as other parts of the hospital that you might be able to imagine, like the emergency department, let's say. I think it's generally kind of the people in the reading room are generally like chill and humble, laid back, like not a huge ego. And I like this for my own workflow. I want to show up to work. It's very distracting to have loud noises going off, bells and whistles from the ICU, or the high-pitched ventilator noise. There's not people yelling in the hallways or vomiting. Like, you get the idea. It's a little bit more of a peaceful place. Of course, it can be stressful, when it gets busy and stuff. It's not to say that there's no stress. After all, patient lives are on the line with your report, which is easy to forget when you're looking at a computer screen. But that's why we do intern years, so that we know like exactly what's going on. So my last point here was that imaging is, I heard this in med school, imaging is the physical exam of the 21st century. So this is kind of illustrated by the doctor here saying, still let's do an x-ray just to make sure, I don't know, the skeleton, what their chief complaint might be. But what I mean by this is that in med school, you have to learn how to do a very thorough history and physical exam. So what does that mean? That means that you talk to the patient, you figure out what their medical history is, their surgical history. You get a really detailed, like, kind of review of systems with what symptoms that they're having. You figure out what their allergies are, what their meds are, et cetera, and so on, what vaccinations they've had. And then you proceed to do a physical exam. And so you actually touch the patient, you palpate them, you press on their body physically, you do certain specific maneuvers so you can diagnose things, maybe. You also auscultate them, like you listen with your stethoscope to their heart and lungs and their belly. But sometimes patients, either they can't give you a very good history for one reason or another. You can imagine, some reasons why that might be the case. Other times patients have a breathing tube in where they just can't cooperate. Other times patients just physically won't cooperate with your physical exam. They might be obtunded or lethargic, or you get the idea. There's so many scenarios where you can't really do a good exam. And so the CT scan oftentimes has all the answers. So this is quote unquote the donut of truth. Yeah, oftentimes, I mean, you just have to scan people. You have to scan people just to make sure you don't miss anything. In med school, we learn about the physical exam and the, endless list of maneuvers that you can do. And it's extremely important. Of course, it's also important for boards. So, you need to know how to do a very good physical exam. But in real practice, like I said earlier, sometimes you just got to order the CT scan and figure out what's going on. All right, so I'm going to end with the reasons why I chose it with the 5 final reasons. So I talked about this a little bit earlier, but there's a lot of career flexibility, I think. So there's tons of fellowship options. So you have interventional radiology, breast imaging, abdominal imaging, pediatrics, neuroradiology, so like brain stuff, not orthopedics, musculoskeletal radiology, and you have nuclear medicine. I think that's everything. So there's so many different options. So I think this is quite nice because, again, you can have as much or as little patient interaction and procedural work as you care to have. The radiologist is often called the doctor's doctor, and this is not to put down any other doctor. The reason I have this listed here is because I heard it from someone else who was a non-radiologist, and we're basically just consultants. We're consultants for the imaging. So I thought being a consultant was a really nice position to be in. So I felt like I could be a generalist because I know everything about image. Well, I will know a lot about imaging from head to toe in all the organ systems and many medical specialties. But again, so I'm kind of a generalist and a specialist at the same time because the specialty is imaging, basically. Another reason that really resonated with me was kind of what I talked about earlier with the computer desk job aspect of it. So this lends itself really, really nicely to doing remote work, and this is called teleradiology or telemedicine. And so you can imagine you could be reading your X-rays or your CT scans at home in your underwear in your own comfort. So, whatever floats your boat, I think this is pretty cool. You can live elsewhere and then read for a hospital that is in the States, for example. And I think in general, I think in our specialty, we do have some semblance of work-life balance. There is no way to kind of divorce the stress of being a physician and the stress of like a patient's life being on the line and making mistakes. There's no way to separate that from the job of being a doctor. There's just no way to do it. But I think in general, we do pretty good in this department. So, and shift work. Again, this kind of ties in together here. So, this is kind of depicting the importance of shift work. There are other specialties like anesthesiology and emergency medicine that also have shift work. So it's pretty nice to know like when you're done with your work at the end of the day, and that it's nice to know that you're not taking work home with you. So the exception to this is interventional radiology because they have to take call because oftentimes there are emergencies that only they can address. And so you have to have a pager on you, and you might get paged in the middle of the night, or have to go into the hospital in the middle of the night to take care of an emergency. So just things to think about. This is again illustrating shift work. So this is the emergency doctor coming down, asking for a scan, the minute before you're done. And it's not like we're going to hide and like not read it, right? We're going to read the X-ray. Let's say it might take like 2 minutes. It's like pretty quick. If it's a CT scan, of course, it could take longer. It might take 20, 30 minutes or 40 minutes. But it's not like you're stuck at the hospital like significantly longer after your shift. I've had shifts in residency where I'm on call till 7 p.m. and then I'm still at the hospital like 10 p.m. Before I get to leave because I had to like do so much chart review, and there's just so much that you have to do in addition, chart review, documentation, talk to your senior resident, talk to the attending. So yeah, it's nice to, just do your work, and then, shift work is nice is what I'm saying. Okay, so we talked a lot about the medical aspects of radiology. I'll talk about the non-medical aspects as well. So if you're wondering how many scans per shift that we might read, so a shift might be like It might be like 8 or 9 hours, or like 12 hours long, or 10 hours long, somewhere around there. It would be pretty uncommon for it to be longer than 12 hours. In residency, we do have to do a little bit longer than 12 hours sometimes. And the amount of scans that you might read per shift can range anywhere from like 50 to 100 to 100 to 200, depending on kind of what you are reading. Again, like, is it it's going to be a combination of X-rays, CT scans, MRIs, and ultrasounds, as well as like nuclear studies and procedures, of course. So I think of the vacation and salary department, we do fairly well. You can Google all of the numbers for this. It would not be uncommon for radiologists to have more than 6 weeks of vacation per year. I think anesthesiologists do pretty good in this department as well. And there are differences between private practice and academics, as well as rural versus urban. So 90% of radiologists are in private practice. So odds are that you will likely be in private practice. And the rest are in academics. So academics means that you are at a large university academic center. Typically, these are in urban environments. So basically, if 95% of radiologists are fellowship trained at this point. It has become increasingly common to do a fellowship, if not two fellowships. So I think one fellowship is enough. So if you want to work in a more urban environment, you likely need to do a fellowship. Whereas if you are in a more rural environment, there is less of a need to do fellowship, because you would likely be more of a jack of all trades or a general radiologist. So again, I hope that kind of colors your understanding of the different practice styles that you can have. In academics, if you are fellowship trained, let's say in neuroradiology, so like brain and spinal cord imaging, then you will 90 to 100% of that time be reading neuroradiology. Whereas in private practice, you might be reading brain and spinal cord imaging more like 25 to 50% of the time. And then the rest of the time will be spent doing general diagnostic work. So there are, again, differences between all of those practice settings. So how many weeks of vacation do radiologists get? This is referring to attendings, right? In residency, my program has 4 weeks of vacation, or 20 days. So it would, again, not be uncommon to have more than 6 weeks of vacation. If you work if you're like a professor at like a university medical center, you might have like maybe less than 6 weeks of vacation, but then you have 1 academic day per week, which is kind of like a freebie. Like, you can use it to do what you like, schedule meetings, talk to medical students, do research, et cetera, and so on. So, it kind of breaks up the monotony of doing clinical work. So yeah, I think this is quite nice. Do radiologists feel fairly compensated? So of course you can look at the average salaries, which vary dramatically depending on the geography of like where you are practicing, but it seems like most feel fairly compensated. So I think this is important to talk about, especially in times like now where we have such a large student debt burden. And I mean, this needs to pay off in the end. I don't think it needs to make like financial sense as well, right? So let's talk about some of the procedures that we do. So this cartoon, it's like, I'm wise. It's like, are you the medical student who's going to be the see one, the do one, or the teach one? So there is this saying in medicine, you basically see a procedure or a surgery, and then or a certain type of patient presentation, and then you're able to teach it after like doing a handful of them. So if you're in musculoskeletal radiology, then you might be doing something called joint injections. So we can put a little bit of steroids in a patient's, let's say, shoulder joint or knee joint, fill in the blank joint, could be the ankle. And if they have very severe pain in that joint, then we can alleviate that pain by putting some steroids in the joint, which is anti-inflammatory. And we use basically a live X-ray machine to see exactly where we're putting our needle. So MSK radiologists also do bone biopsies. So oftentimes you'll need to get a sampling of the bone in order to determine if something was cancerous or not. So basically to rule in or rule out bone cancer. If you're in neuroradiology, you might be doing something called lumbar punctures. An LP is basically a procedure where you put a needle in the very low back near the spinal cord, actually in the spinal cord, and then you get some cerebral spinal fluid out. And that is basically fluid that bathes the spinal cord in the brain. So it's kind of like brain fluid. And you get a sampling of this, and then you can send it off to the lab and test it for basically meningitis or other inflammatory or infectious processes, or even autoimmune diseases. So a neuroradiologist could use live X-ray in order to do a lumbar puncture, which is pretty cool. If you're in pediatric radiology, you might be doing something called an intussusception reduction. So an intussusception is when the bowel kind of telescopes on itself. So the bowel should be nice and tubular, right? Kind of peristalsis to move poop along in your digestive tract. And then sometimes it can get tangled and kind of telescope on itself. And then this is a pediatric emergency. So a radiologist actually is called in to reduce this, or to like make it go back to its normal shape. And this is done through a air contrast enema. So that would be a intussusception reduction. Of course, you can find videos of all of this stuff on YouTube. Just trying to like color your understanding of all the variety of procedures that we, even if we don't do them as attendings, we learn how to do them in residency. In abdominal imaging, you might be placing a little tube or like a drain in an abscess, which is like a collection of pus from like an infection intra-abdominally, like in the abdomen. So you would be using a CT scanner actually to guide exactly where you're putting your tube. And this is, of course, therapeutic for the patient. So that's a pretty cool procedure. In breast imaging, you'll be doing tons of ultrasound-guided biopsies to basically determine if a lesion in the breast is cancerous or not. So there's quite a bit of women's health, public health, and kind of oncological work in breast imaging, which is pretty cool. And in interventional radiology, there's over 200 different procedures that they learn how to do. Of course, some are more common than others. Some are quicker than others. Some take upwards of 6 hours. Others can take less than an hour. So I think one of the main things that makes IR very different from other even surgical specialties is like how much variety there is. I mean, the world's your oyster, basically. So if you like procedures or like, it's basically minimally invasive surgery using imaging to guide exactly where you're going. So you become an expert in using things like ultrasound and live X-ray, like fluoroscopy, and CT scans to do procedures. So if you like procedures, this is definitely the reason to do it. But this is also the reason not to do it. So if you find that you don't necessarily like being on your feet and wearing a lead-lined scrub cap and lead-lined glasses and a lead thyroid shield and a lead shirt and a lead skirt to protect your reproductive organs, you get the idea. This stuff is heavy, and if you're on your feet for 8, 9, 10 hours, 12 hours a day, it can be physically exhausting. So it just depends on like whether you want to be physically exhausted or mentally exhausted, I guess. Let's talk about residency briefly. So I mentioned how at the end of my first year of intern year, so radiology residency is basically 6 years long after medical school. So it's quite long, and it takes basically 14 or 15 years after high school. So for me, after high school, I took 2 gap years, so that'll be 16 years total. I didn't even know what a radiologist was even before med school, really. Or, in high school, I had no idea that this job even existed. So I'm at the end of my intern year, and so I'm doing a transitional year. So a TY year is kind of a mix of internal medicine and surgery. So you could do a intern year which is only internal medicine or only surgery or like primarily surgical rotations. Then of course you match into a residency program by going through the matching program over here. After intern year, you do 4 years of general diagnostic radiology residency. So 1 + 4, that puts us at 5, plus 1 more year of fellowship, 6 years total. And these are many of the fellowships that you can do here. So the exception to the 1 year of fellowship rule is neurointerventional radiology, because these are kind of like minimally invasive neurosurgeons. And so they take stroke call and they treat strokes. So that's pretty cool. But this fellowship is 2 years long, and so that can be a 7-year training path. And there's many different paths to get to interventional radiology. You can directly apply to it, and that's a 6-year path. You can do early specialization in interventional radiology. So basically, you are a diagnostic radiology resident, and then somewhere in 2nd or 3rd year, you switch over to the interventional path. That's also 6 years long. Or you can do, 1+4 and then 5 years, and then do a 2-year IR fellowship that is dedicated only to IR. So again, it could take you, up to 7 years in total in residency. So just to kind of color your understanding. And for example, I just completed my internship, my transitional year program at Hennepin County Medical Center. And they have an affiliation with the University of Minnesota here. So I am technically a university employee, and will be primarily spending my radiology time at the university. So this is just how my program is built. Many other people do their internship in other states and then move like to wherever their radiology residency is. So there's many ways to do it. In radiology residency, this is kind of how we learn. So, you'll take a break somewhere, handful of times throughout the day and talk with your attending and kind of go over basically what you missed or what you got right. And, you really did a good job on this report. Wow, like you really crushed it. And then you're like, oh, thank you. And then the attending is like, just a few changes. And then they're going to delete this, change that, reword this. And, this is kind of how you learn, because you're going to inevitably miss things. You're going to get some things right, of course. But when you miss things, that's really where you learn. And then you'll also kind of pick up like your style, like, everyone likes using different words or like phrasing things a certain way, or like some people are much more clinical in the way they phrase things. Some people are more theoretical with how they phrase things. So, this is just that's just residency basically. So yeah. So what about AI? I'll talk about AI and then we'll kind of move on to some questions maybe. So this is Dr. Cellini. He is a fantastic YouTuber. If you don't know him, go check him out on YouTube. And he did a video on whether AI will replace the radiologist or not. So I encourage you to do some YouTube research about this topic if I'm not convincing enough today. So people have been talking about how AI is going to replace the physician since 1976, believe it or not. And there was an article in the New England Journal of Medicine that talked about how algorithms are going to replace the internal medicine doctor, the hospitalist, the internist in the hospital, basically, because, quote unquote, all they do is interpret objective data metrics like vital signs and lab work and things like that, and that a computer could do this. So lo and behold, we still have hospitalists in the hospital. They're doing just fine. So people have been trying to predict when AI is going to take over the human race for quite some time. So I guess what I'm saying is don't believe the hype quite yet. That said, it is very, very exciting. It's a very exciting field of research. And it's not only radiology that is embracing AI, it's also ophthalmology and dermatology and pathology. So AI is super cool. Here are some of the some of the hurdles and things that we have to think about before we truly embrace it with open arms. So humans are inherently biased, and the algorithms that we build will inherently have bias as well. So something to think about. If you ask the tech people, how are we going to correct for this bias? Well, they're going to tell you, hey, I can build an algorithm to correct for the bias. So it's kind of like asking a surgeon, what about this problem that was caused by surgery? And then they're like, I think we need more surgery. You know what I mean? So I think we just need, I'm not saying, like, obviously that might be the case clinically for a patient. I don't know. But we just need to think about bias and just do our best to address it, I guess. There's this explainability issue. So the algorithms are basically like a black box. So you feed in a bunch of data and then it spits out like a result. And then it learns kind of in the middle. It has like a neural network where it learns. And there's no way for you to like go up to the algorithm and be like, hey, how did you deduce that you thought it was this diagnosis over that diagnosis? You can't ask it, how did you come to this conclusion? But you could walk into the reading room and ask the radiologist, why did you think it was this over that, for example? So there's this explainability problem. There's also a reproducibility issue. So this is generally an issue in science, I think, because laboratories and universities have such advanced technologies that it's so hard for one lab to replicate the results, or even the methods, more importantly, the methods that another lab used in order to get a result or to publish a paper, for example. So are these startup tech companies, are they going to want to share their proprietary technology and then have that be verified by like third parties who are like, I don't know, don't have like a shareholder stake? Like there's this is something to think about as well. Of course, software gets hacked and it can glitch sometimes. Who's going to oversee the software tool? How is it going to be implemented into the existing software? We already have like software called the PAC system, or the Picture Archiving Communication Service, or system, and that's just a system that basically every radiologist uses. So there needs to be a way to kind of incorporate these tools into the existing infrastructure, I think. Also, like, who's going to own the data? Because if you're using an algorithm, it's not like, it's not like they're not going to see the image that comes through in order to give a read, for example. Like, they need to see the image. So there will be, I don't know, is it going to be the tech companies that own the image? Is it going to be the hospital, the patient, the radiologist? So lots of questions to be answered here. There's some other questions here that I'll leave for you guys to ponder. There are other like way lower hanging fruits that AI could be used for, scheduling. I mean, this is a no-brainer here. Or even just like triaging studies. This means basically like you could use the algorithm to like briefly scan the list of a freshly produced image, and then basically if it thinks it's something life-threatening, then they could just flag it or like notify the radiologist, and then they could read it read it like fast. So that certainly triaging is a low-hanging fruit, I think. So basically right now the algorithms are really good, but they have very narrow application uses. They're very good for like only one or two things at a time. You also want to think like, what would my mom want? What would my brother or sister want? What would my grandparents like? What would a patient want basically? Would they trust it, or would they want like a human there, like just in case, or to kind of oversee things, or to like go to with questions and stuff? So I think for these reasons, basically AI will supplement the radiologist to improve patient outcomes. It's going to be just another tool to make us more efficient, more accurate, just better at our jobs. And I think the practice of radiology will look dramatically different in about 30 years than it does today. And I don't consider this a negative. Some people might see this like, oh, I don't know if I'll have a job in 20 years, but most radiologists will say that we will have a job. It just will look different, just as the practice of radiology looks different today than it looked like 40 years ago, for example. So yeah, this cartoon here is illustrating the importance of litigation and what happens when the robots get sued for missing a diagnosis. What happens then? Do the tech companies take blame? Who's gonna? I don't know. Somebody needs to kind of fess up and kind of. I don't know. At this point, we have malpractice insurance. It's just part of the job. So, yeah, things to think about. Here are some misconceptions which I hope we have addressed. And I think there's this myth that all radiologists just enjoy being in a dark room and are antisocial and socially awkward. This is not the case. Many of my co-residents and we enjoy being outdoors, like doing like fun things in the cities here. And of course, some people think that we don't see a single patient, but we do see patients. So some people think that reading imaging is easy. I'll show you guys some imaging in just a couple slides, and we'll talk about that as well. Not all scans have, importantly, ionizing radiation. So, of course, CT scans are probably the worst offender here. And then ultrasound and MRI are very, very safe, if not like the safest. And AI will not replace the radiologist, is my never humble opinion. So yeah, I'll stop right here, take some questions. I see the chat's kind of going on, and then we'll get into like kind of clinical cases and just talk about x-rays and some anatomy and stuff like that. So yeah, let me know what you guys think so far.
So I can go ahead and read some of the questions we have over here, if that's okay with you.
Absolutely.
Okay, so the first question we have over here is, was radiology a specialty you always wanted to go into? And if not, what made you change your mind?
Yeah, so it wasn't the specialty I quote unquote always wanted to go into, because I think before med school, if you would have asked me, I probably would have just randomly said like family medicine or internal medicine. Like I really had, it's so hard to get a sampling of all of the specialties before med school. So the answer is no. I think what led me down to finding radiology is what this question is probably asking, or what this person is interested in. And in my 2 gap years, I worked at a Google Glass startup, and so I think having this experience at a digital health startup where I got to see like the role of technology and how important or like how much it could change the practice of medicine or healthcare. I think this experience really trickled itself down into medical school. So in medical school, I did some computational biology research. So I was using basically software tools to do some molecular modeling and do some pharmacology modeling. And I really enjoyed like using different software tools to basically do science and to do research. And so you can kind of see where this is going. So radiology is like maybe the most like technologically or like computer-esque job, right? We have some super cool technology, very unique technology as well, and so it's just like very very interesting. So I think that's kind of what led me down the path, and like I basically just did like a rotation in radiology early on in third year and had a very positive experience. People told me that like, oh, you'll never see a patient again, or like you're going to be in the basement in like a dark room, and it's like I don't know. I just it wasn't it didn't convince me, right? So I went through the rest of my third year rotations where you do like family medicine, internal medicine, surgery, pediatrics, OBGYN, and psychiatry. I also did like dermatology and sports medicine just to kind of, suss things out. And I still, at the end of that, every time I would think back to that experience in my radiology rotation, like how positive of an experience that was. And then I just continued the exploration of that interest during my fourth year of med school, and that's kind of how I came to radiology. Long story short, so.
Okay, thank you. That's really, really interesting. So another question we have over here is regarding the AI segment of your presentation. So expert systems can diagnose illnesses, but do you think people would trust robots to perform procedures?
The answer is no.
Okay. Thank you so much. Okay, this one's really interesting. So this member of our audience asks, have you ever spotted someone with DID from MRI scans?
What is this DID? What diagnosis are they referring to?
With like clarification from the, oh, there we go. Dissociative identity disorder.
I'm not sure how you would diagnose that because that's a psychiatric diagnosis. So that's a clinical diagnosis. So I don't think you would require imaging to call that. But that's an interesting question because maybe there are some MRI findings that I'm unaware of. I don't know.
Okay, thank you. So another question we have over here is, would you go for neuroradiology and why or why not?
Would I?
Yes.
If you put a gun to me, or if you put a gun to my head right now, and you're like, you got to pick, then it'd be a toss up between musculoskeletal radiology and neuroradiology. So neuro is super cool. I just actually finished a neurology rotation and really really enjoyed it. I never did a neurology rotation in med school, so I didn't really know what to expect. But there's lots of imaging in the specialty of both neurology and neurosurgery, and they have some of the most interesting diagnoses. So for sure, I'd consider it.
Okay, wonderful. And for our last question, so you can begin with your cases, and then we will, take the rest of the questions for the Q&A. So what does a regular week look like for you as a radiologist?
So I'm not a radiologist quite yet. I'm at the end of my intern year, so there is no typical week. If you want to see some of the vlogs that I've done on my Instagram stories and my highlights, every month, intern year is very disorienting because every month you're on a different specialty, there's different hours. So if you want to check out some of those vlogs, just kind of get an understanding of like when I'm going into the hospital, when I'm leaving, and when I'm doing night shifts and stuff. The typical hours of a radiology residence, which I will be very familiar with in about a week or two, it's basically 7:30 to 4:30. And then throughout residency, you'll have to do call for, I think, 6 or 8 weeks total throughout the 4 years. And so there will be a handful of weeks each year that you have to do call where you're working like an evening shift or an overnight shift. That's kind of what the hours look like. So it's like, 50 hours a week, I would say, you know, plus or minus, with less busy rotations and more busy, call shifts. So it depends, but it's certainly not as bad as other specialties where you hear people working like over 80 to 100 hours a week. So another reason why I chose it, because the residency is somewhat manageable.
Okay, well, I did not know that some people would go 100 hours per week. That's crazy. Yeah, very busy, definitely. So, one last question before we go on into cases. So, this member of our audience says, it'd be great if you could speak more on osteopathic medicine, OMT, and how you feel about the philosophy for those interested in pursuing a DO.
Yeah. Um, so there's no. Let me preface this by saying there's a physician is a physician is a physician, like MD, DO, Caribbean. If you're international, have an MBBS. We're all physicians at the end of the day. So depending on, I assume that this is a either a high school student or a college student who is asking this question. And there is zero reason to even consider this question until you have at least one medical school acceptance. So what do I mean by that? I mean that you need to either be accepted into both an MD and DO school. You basically have to have the scenario happen to you where you have an acceptance of an MD school and a DO school. If you only have a DO school acceptance or only have an MD school acceptance, then this scenario really doesn't matter, right? Um, so the whole goal is just to become a physician. So I thought that the DO philosophy really resonated with me because there's a big emphasis on prevention and primary care, as well as kind of the body working as a unit and the body being kind of self-healing. And I thought that it'd be pretty cool to get a really strong understanding of the musculoskeletal system and sports medicine and using my hands, like osteopathic medicine that you all may be familiar with. So if you're not familiar with the manipulation aspect of DO school, then it's basically like combination of physical therapy with chiropractic is the best way I could describe it. So, I went through osteopathic medical school and just found that I was not personally interested in doing manipulation. So you will figure out for yourself once you're in a DO school whether you want to have that as part of your practice or not. So yeah, like I said, like this scenario, I mean, that's what I'll say about MD versus DO, because there is no verse, like we're just colleagues, right? So we're all just physicians trying to take care of the patient to our best of our ability. So as a DO, you'll have one extra tool in your pocket potentially to use. That said, I think only 10% of DOs even use the manipulation skills that they have. So I think just most doctors in general just don't use it. And some MDs even actually pursue like training or education in the manipulation. So it's not like you'll be an MD and you'll never learn this stuff. Like you can easily learn this stuff. So there's a lot more, I think, crossover than sometimes is alluded to on the interwebs. So I hope that's helpful.
Thank you so much. You can go ahead and work on the cases.
Sure. All right, guys. Let me know how you guys are doing in the chat here. It's fun to see the chat kind of be popping, and let me know how you guys like the memes. And so we'll just have more pictures and stuff like that. This will be, if you haven't taken anatomy, then this might be a little bit overwhelming, but don't worry about it. Just like kick back and like enjoy the video. So this is a chest X-ray. Some of you may have seen one, others you may have not. I'll just start by getting you guys oriented. So, of course, this is the chest, of course. This is the left side of the body, and then this is the right side of the body. So down here, we have things that are more dense, like the liver and the stomach. And the heart, of course, this kind of looks like a heart, right? So the heart kind of sits to the left of the chest. And then the lungs are here. The lungs are black because they have air. So air is less dense. So an X-ray works by basically shooting photons at the body. And so the more dense tissues, like the heart, for example, and the bones, they appear white because they are more dense than air. So In radiology terms, opaque means white, so something that's radiopaque is white, and then if it's radiolucent or lucent, that means that is black. So this just refers to with like light passing through the body, basically, or photons passing through the body. Let's go over some anatomy real quick. So we have, of course, the windpipe, the trachea coming down here, and then it comes kind of, it bifurcates here at the carina. Bifurcate means split. So it splits into the left bronchus and the right bronchus, and then this splits into the lungs, kind of like a branching pattern, right? Like into alveoli. And the lung has different lobes. So we have the apex, or the top of the lung, and we have upper and middle and lower zones or lobes of the lungs. And then we have the, again, similarly, apex, upper, and then lower here. And then you see kind of the ribs kind of coursing through anteriorly, which is like kind of in the front anteriorly, and then also posteriorly, so in the back as well. And so you can kind of see the ribs. This is a posterior rib, and then an anterior rib kind of coming more angulated down like this. See that both on the right and left side. So in addition, we have all sorts of bony anatomy or osseous anatomy. So that's, we have the clavicle here, left clavicle. Distal means farther away from midline. So this is the medial clavicle, meaning that it's closer to the midline. So, you know, midline is just in the middle of the picture. So oftentimes using symmetry really helps us. We have some very basic geometric tools in radiology too, like little rulers and stuff, and ways to measure angles too. Of course, here we have the right atrium, and then we have the left ventricle of the heart. These are all just chambers of the heart. And yeah, of course, I said the stomach kind of sits over here. The spleen also sits over here. You can imagine lower down here, we have the pancreas, and then the liver over here, and then the gallbladder might be a little lower. So this is another nice overlay with much of the same anatomy that we just saw, just to kind of color it differently so you guys can learn by, I guess, osmosis. And you can see this is depicting more of the vessels. This is the superior vena cava coming superiorly and then draining into the right atrium, and then the inferior vena cava kind of coming inferiorly into the right atrium. Superior means like up or like high, and then inferior means, it doesn't mean less than, it means kind of lower or coming from downwards. Of course, we have the lobes of the lungs again here, depicted quite nicely. We have the aortic arch here, the aorta, very important blood vessel, of course. And then some abdominal anatomy here, which we'll see in just a little bit. And this is a CT scan. So this is a cut kind of in the coronal plane. So this is kind of a slice like this. So if you can imagine this plane is kind of, you can kind of scan through this image kind of frontwards and backwards. And then if you had a slice that was kind of like a sagittal, or this red slice here, then you can kind of scroll through the image left and right instead of front and back. And then we'll see some transverse plane or axial planes. And these are cut kind of like this, kind of like slicing through the body. Of course, they're all slicing through the body, but they're slicing through differently. So this transverse green plane, that could scan up the body kind of like this, right? So you have kind of like this, up and down, you have left and right, and then you have forwards and backwards, so to speak. So this is a CT scan, and this shows much of the same anatomy again, but it shows it a little bit differently. So this shows a little bit more spatial resolution or spatial separation. So you can kind of see the tissues separate a little bit better. You can see the liver a little bit better here, stomach. You can see the esophagus back here, and the spleen over here. So, all right, first case for you guys. We'll go through it pretty quickly, but in the chat, just like leave a little comment with like what you think the diagnosis is as I start describing this case. Some of you will get it immediately, and others of you, you'll get it in med school. It doesn't, it doesn't matter right now. So in front of us, we have a chest X-ray, and the arrows are, I'll just tell you, pointing at something. I won't say what it is quite yet, but this is a 65-year-old female, and she has a history of COPD, or chronic obstructive pulmonary disease. This is a form of lung disease where your lungs get trashed by smoking tobacco most commonly. So bad lungs, presenting with a fever. So her temperature might be like over 102 degrees Fahrenheit or 103 degrees, and complaining of shortness of breath, or dyspnea, or difficulty breathing. So basically having a hard time to breathe, been having a fever that's pretty nasty for the past 3 to 4 days. Also coughing up sputum, so sputum production. The sputum, you might ask her like, oh, what color is it? And she might tell you it's like green or yellow in color. And then, once you start asking more questions, she's like, I'm also having chest pain when I breathe, when I take a inhalation or when I inspire. So this is called pleuritic chest pain when you breathe inside, where you take a deep breath in and then you have chest pain. So if you take a look at her vital signs, like the nurses can help with kind of measuring like heart rate and respiratory rate, meaning like how fast their heart is beating and like how fast they're actually like breathing, and also like what their temperature is and what their oxygen saturation is and things like that. And tachypnea means that they're breathing fast, and tachycardia means that their heart rate is beating fast. So her heart rate might be like over 100 beats per minute, like 110, let's say. Tachypnea respiratory rate might be like over 30 breaths per minute. That would be pretty fast. And then you also will examine this patient, of course. And if you put a stethoscope up to their chest, let's say you put the stethoscope up to the right side of the chest or on the kind of posterior side of the back here, and you might hear kind of these popping sounds. These are kind of called crackles, and you might hear them on the right lower part of the lung. And then this might prompt you to order some basic lab work like a metabolic panel or a complete blood count. So if you get a blood count, then a white blood count, white blood cell count will also be in that lab panel. And if the white blood cells are elevated, then that's called a leukocytosis. Another word for white blood cells is leukocytes. So that's where this word comes from. So leukocytosis. And I guess let me know what you guys think your differential diagnosis is. Like what are the top 3 things this could be, or like 10 things that this could be. You want to kind of formulate a broad differential is how kind of doctors think about this stuff. But yeah, basically lung disease, fever, difficulty breathing, nasty sputum, hurts when she takes a deep breath in, breathing fast, heart is beating fast, something going on with the lungs here, popping sounds, and then white blood cells are elevated, and typically they are elevated in some sort of infection or inflammatory process.
Okay, so we do have a few responses in the chat. So we have, let's see, bacterial pneumonia or a viral effusion. I can't pronounce this one, but it's emphysema. And then there's tumor or lung infection, another pneumonia, lung cancer, lung infection. So this is kind of the general gist of the responses.
Nice. Yeah, you guys nailed it. So the way I would describe this is that it's an opacity, right? Because it is more dense here. This should not be here. Lungs should be black, kind of how the left side is here. So this is a right lower lobe opacity. So it's in the right side on the lower lobe of the lung. This is all consistent with the bacterial pneumonia. So whoever said bacterial pneumonia was spot on. If you're wondering, like, how are we going to treat this in the hospital? Well, something like intravenous antibiotics is probably going to be on the menu. This is going to help treat the infection. And then, of course, you can do all sorts of other things like give the patient oxygen if their oxygen's low, and et cetera, and so on. So nice. Awesome. And speaking of pneumonias, this is a COVID pneumonia. So this is a CT scan of the chest. We saw a CT scan of the chest earlier, so looks pretty similar. Also, if you're enjoying these images, then I encourage you to check out the Radiology Guy, super cool Instagram page. This patient basically has peripheral ground glass opacities. So what does this mean? So it's peripheral, so it's kind of on the periphery of the lungs rather than kind of more centrally located in the lungs. So again, this would be the periphery. Ground glass opacities, that just means that this is like junkiness in the lungs. This should not be here. So this is all caused by the COVID infection, the COVID pneumonia. Vascular dilation, that means that the blood vessels are a little dilated. They're kind of opened up abnormally. So this is kind of what a COVID pneumonia will look like. So, all right, nice work, strong work on the first case. On to the second case here. So again, we have a chest X-ray. The arrows may be pointing at something in the chest X-ray. And again, just let us know what you might think the diagnosis might be in the chat box. So this is a 58-year-old male. So he has a history of coronary artery disease or like heart disease. Typically, this is caused like when the blood vessels that are feeding the heart, when they get blocked off. And also presenting with difficulty breathing or shortness of breath. This is not just SOB. Another word for shortness of breath is called dyspnea, where it's just like difficult to breathe. And he has something called orthopnea. So what this means is that this patient requires like 2 pillows. So I have some pillows back here. He requires 2 pillows to prop himself up at bed at night in order to breathe better, because when he lays flat, this exacerbates his breathing. So this makes his breathing worse. So when you're more upright and this helps your breathing, this is called orthopnea. This patient's respiratory rate is 30 breaths per minute. Like we talked about earlier, this would qualify as tachypnea, so breathing pretty fast. You can test the oxygen saturation level with like a little oximeter, like a little piece of tape that it almost looks like a piece of tape that goes on your finger. I can tell your oxygen levels. And if you auscultate with your stethoscope, if you auscultate or take a listen to the lung fields with your stethoscope, you might hear something called rales. So rales are kind of these high-pitched whistling sounds. So it's different from crackles. It's different from normal heart sounds. It's different from wheezing. So if you hear rales and this guy has a history of heart disease, difficulty breathing, and kind of has this respiratory status, this clinical picture, typically we like the oxygen saturation rate to be over 95%. So this would be a little bit low. So it'd be hypoxemic, a little hypoxemic. So what's the differential here? And I'll talk about this right here in just a moment. So, you've done a physical exam or somewhat of a physical exam, then you order some blood work, like a basic metabolic panel or a complete blood count. So we got a CBC, a blood count earlier, and you might also get a specific lab value called a brain natriuretic peptide. So this is very specific for the diagnosis that we're about to talk about. So if it's very high, then it likely means that the patient indeed has the diagnosis that we're going to talk about. So what do you guys think the diagnosis might be?
Okay, so I can see that this one's stumping us a little bit. We're kind of confused. It's like I'm thinking maybe it definitely has to be related to the heart disease. Yeah, because someone in the audience also said this was a little bit hard. Someone does say interstitial lung disease or BMP related to the heart.
Oh, nice. Yeah, I can't see the chat, but maybe someone said interstitial lung disease. That's a really good that's a good differential actually. So this is all consistent with heart failure. So congestive heart failure. So sounds like some of you guys were almost there. So the way we can describe these opacities, where the lungs should normally be kind of more black, these are all opacities here. They are kind of fluffy, bilateral. They're on both sides of the lung, so on the right and on the left. Unilateral would be the word for only one side. They're perihilar. The hilum of the lungs is kind of like right here in the center, so they're kind of like near the hilum. They have kind of a bat wing configuration or angel wing, if you can imagine, kind of like this. This is all consistent with basically fluid in the lungs that is caused from heart failure. So another finding that we have here is called cardiomegaly. So cardio means heart, megaly means enlarged. And so this patient has an enlarged heart. So if you can kind of follow the silhouette of the heart, you see how it kind of follows like all the way to the edge of the lung field here, basically to where the diaphragm is. And so that's like pretty big. And then you can see the silhouette of the heart on the right side is also enlarged. So if you remember the x-rays that we saw earlier, the silhouette of the heart kind of ended like right here. So it was about halfway of the distance from the hemidiaphragm, or half of the diaphragm. So this patient has an enlarged heart. So basically they have congestive heart failure, and what I listed here is PAE. This is pulmonary alveolar edema. So pulmonary edema means fluid in the lungs. So treatment for this is going to include all sorts of different medications for the heart. But one to know about is intravenous furosemide or Lasix. And some of you may have heard this in the hospital or in the emergency department. And this is a really powerful diuretic in order to help this patient basically pee off all the fluid in their lungs, and to basically improve hopefully we can improve this respiratory status, because this is bad news bears, not so good. So yeah, heart failure basically. And the BNP, you learn about the physiology of this. This is a brain natriuretic peptide. You'll learn about this in physiology because this is elevated. It's very specific for the diagnosis of heart failure. So, okay, so there's a saying in radiology that one view is no view. So what does that mean? So I only showed you guys one view of the chest earlier, but when we're getting chest x-rays, we always want to get a side view or a lateral view because for this reason exactly here, because you can oftentimes get tripped up by looking at something that is three-dimensional in just one view when you only have a two-dimensional picture. So this is why we want two views. So this is a sideways or a lateral view of the chest. So oftentimes things can hide behind the sternum or behind the heart here. So there's some space here. And so you don't know where exactly this opacity might be. So I know this might be a little confusing, but you can imagine if there is an opacity right here square in the center, well, the sternum is sitting here and the heart is sitting here, right? So it can kind of obscure what is further behind or more posterior or retrosternal or retrocardiac to those organs, basically. So in order to kind of triangulate where an opacity might be or where like an infection might be or a tumor or a mass, we always want to get two views. So one view is no views. And this is the importance of the lateral x-ray, again, demonstrated here. I just really like these memes here. So yeah, you always want to look at things in, you don't want to get faked out, basically, is the take-home point here. So in radiology, you also want to take a look at the priors if you can. So if some of those patients that we saw earlier, the heart failure patient and the pneumonia patient, those patients may have had heart failure or pneumonia before, or they may have had other diagnoses before that has changed their current anatomy. So you always want to take a look at the priors. So if they've had prior imaging, you always want to take a look at that. So it's something that we also do as radiologists. Here we have some metallic objects here. You can see the meme here. And we'll see all sorts of metallic or radiopaque objects in radiology. I'll show you guys some funny ones in just a little bit. You'll see surgical hardware, and then you'll see just regular hardware, just everyday stuff. So yeah, here's a X-ray of the hand. I'm not going to go through all this anatomy with you guys. That would be incredibly boring. I'll just point out the little scaphoid bone because this might be an interesting bone to know about when you get to medical school and start learning about the orthopedic injuries that someone can have. So remember, the scaphoid can be injured. That's all I will say right now. Here's a C-spine or a cervical spine lateral film or lateral X-ray. So you see the cervical spine here. You can also make out the trachea here and then the epiglottis. Then the spinous processes are kind of these pointy things that come out the back. And yeah, that's a C-spine radiograph. So again, radiograph and X-ray are the same thing. So this is a shoulder radiograph. So sometimes we can see shoulder dislocations. This one's completely normal. But in addition to kind of seeing the humerus and the clavicle and the scapula and all of the shoulder anatomy, there's also blood vessels that are all here. So we're also responsible for the lung fields here. So if there was something like a collapsed lung or some sort of tumor or mass here, like the radiologist is responsible for everything on the image, not just the shoulder, just because it was like, let's say this X-ray was ordered for shoulder problems, for example. Moving along here, this is a elbow X-ray, just to kind of demonstrate the anatomy. Again, we have the humerus and the radius and the ulna. You guys may have heard of some of these bones. Of course, there's blood vessels and nerves and tendons coursing through all of this. This is an example of what breast cancer might look like. So, of course, breast cancer, I've talked about breast imaging in our in the subspecialty of radiology. Here's the pectoralis muscle here. You can see it here. And then the armpit or the axilla would sit here. We also have ultrasound in our specialty. So we can use ultrasound to take a look at the liver to see if there's like fatty liver disease. We can take a look at the gallbladder to see if the patient has gallstones. We can take a look at the kidneys to see if the kidney is like swollen, if there's like fluid in the kidneys from some sort of obstructive process that's further downstream in the ureters, for example. We can use the ultrasound to take a look at the heart for an echocardiogram. So the ultrasound is very, very useful. Of course, you guys know that ultrasounds are used in obstetrics and gynecology to look at all sorts of pelvic anatomy and also at babies, which is pretty cool. So because it's pretty cool to learn a little bit of gynecology and obstetrics in radiology residency. So this is some intra-abdominal or abdominal imaging. So this is a CT scan, and this is the liver that sits on the right, the spleen and the stomach that sits on the left, the kidney, of course, we have two of them. Well, most people have two, on the left here, and then on the right, and then you can see the end of the thoracic vertebra. Then you have the kind of thoracolumbar spine here. You can see the intervertebral discs. The psoas is, this is just a muscle here. You see some intestines, so cecum, sigmoid colon, jejunum is kind of small intestine. And you can, of course, see the bladder. So I'll show this same abdominal imaging in a different view, just to kind of give you guys like different perspectives. So this is, again, kind of a similar view. This is frontwards and forwards, right? And this is a abdominal x-ray. So x-rays don't give as much detail as CT scans do, as you can tell. So you can't really see exactly where all these organs might sit, but you kind of have to know where they sit in general. So an abdominal x-ray would be more helpful if like these loops of bowel or this colon or the small bowel, if they were like very distended, then you might be able to call that like a small bowel obstruction, or like the bowel is kind of like paralyzed, or like it's not moving, and then the patient has, I don't know, pooped in 3 weeks or something. And then there's like medical treatment or surgical treatment that kind of goes along with that. So that's maybe what a abdominal x-ray or radiograph might be used for. So here we have some tubal ligation clips. So this patient is likely female because they had what's called a tubal ligation, which basically is like when you get your tubes tied. So oftentimes we can see post-surgical changes where they have like little surgical clips left over. And sometimes the patient might have their gallbladder taken out, and you'll see the surgical clips where that used to be as well. So this is kind of that different axial or transverse view of the abdominal anatomy. So again, we have the liver and the gallbladder and the stomach, and then the pancreas kind of courses over midline here. Then you have all sorts of blood vessels kind of in the center here. Of course, you have the vertebra and the spinous process kind of pointing out like this. Then we have the left kidney and the right kidney and kind of the spleen sitting over here. So this is another fantastic radiology Instagram account, The Radiologist. You'll find these just really beautifully done overlays. So it's just the same anatomy, just visualized differently. I think, yeah, I mean, he just crushes it when it comes to this stuff. I mean, it's really, really cool. So this is an MRI of the abdomen. So I just wanted to show an MRI because MRIs show a lot of detail and more of like the soft tissues. And as you can tell, they kind of look different from a CT scan. They look a little different, right? Everything's kind of black and white, but an MRI is really good for like soft tissue and like nervous system or brain and spinal cord pathology or disease. Kind of moving along, kind of moving down the body. MRI is also used to take a look at the prostate gland. And since we're down here, I thought it might make sense to show a pelvic X-ray or a pelvic radiograph. So sometimes we'll get these radiographs in trauma patients because sometimes if a patient has intra-abdominal hemorrhage or like they're bleeding a lot from the inside of their abdomen, then a lot of that blood can be trapped. I think like several liters of blood can be trapped in the pelvic, kind of the pelvis. So you want to see if there's any pelvic fractures or anything like that, or dislocations like hip, hip pathology. All sorts of things could be going on, especially if a patient was like in a car accident or like they got hit by a pedestrian versus car. All sorts of pelvic things could be going on here. So some patients will have things placed in areas where might be questionable, like either what is this or how did it get there. So I'll let your imagination run wild with what this might be and how it got there and where it might be. So this was a cookie jar, actually. So in radiology, we have this kind of joke like it's not a joke really. It's kind of a joke, but we suggest clinically correlating. So what does this mean? This means that we suggest that the frontline emergency doctor just like correlates, our findings, like, I don't know, radio, opaque or metallic object in what appears to be, I don't know, the colon, and then we'll say like correlate that clinically with like what the patient looks like. Cause like, we don't know what the patient looks like in person. Right. So there's this kind of joke of clinical correlation. So, you might say clinical, you wouldn't actually put this in a report, but this is just a joke again, like correlate with the rectal exam. Like you can't actually tell another doctor, like go do a rectal exam. But yeah, this is just a meme from weeks ago, or actually months ago. People seem to like this. I posted this on my Instagram. People seem to like it. So, all right. So kind of moving along here. So here we are taking a look at the aorta. So aorta kind of courses down here, and then you can imagine if you're going past the point where the kidneys sit, a little inferior to that, then you can get what's called an abdominal aortic aneurysm. So this is the abdominal aorta before it splits into the left iliac and the right iliac arteries. And this is a little outpouching. So an outpouching is called an aneurysm in medicine. So if this, we can kind of measure this. I don't know what the measurement of it is here because I don't have a PACS system. But this aneurysm can be measured, and then you can track the measurement over time. And depending on the rate of expansion, like if it's getting really, really big, really fast, then that could be life-threatening because this can burst. So this might require surgical management, like to basically manage this, or it might be stable in size and it might not require surgical management, but we can also see this on imaging. So moving along here, this is a lumbar spine MRI, and many of you may have heard of like sciatica or like radiculopathy or like pain shooting down someone's back and legs. And this is maybe what it might look like on imaging. So this is the intervertebral disc. So it sits between the vertebra, so intervertebral. So this is probably the most common site of herniation, or where the disc kind of slips out and kind of herniates posteriorly or like herniates backwards. And then you can see here how it's kind of compressing the nerve root. So the spinal cord kind of has nerves that come out, and then the disc is protruding and then kind of impinging on that nerve and then shooting pain like down that patient's leg. So the L5 kind of S1, this transition point in the spine, this is most commonly where it happens. The next most common site is just above that at the L4, L5. So it's kind of what maybe a slip disc or like sciatica might look like. So since we're moving kind of down the body now we're in the knee, and of course you have many bones that you likely may have heard of, like the patella, the femur, and the tibia and the fibula. Of course, you also have the ACL or the anterior cruciate ligament, and then the PCL, and these are often injured from kind of twisting injuries, and like skiing injuries and football injuries and basketball injuries, stuff like that. Of course, you also have other ligaments, notably the medial collateral ligament and the lateral collateral ligament, which is more lateral to the body, and then the MCL is more medial to the body, so closer to midline. So, of course, we have the menisci, the meniscus sitting kind of in the middle as well. Another picture of the knee here, just the same anatomy again, kind of labeled a little bit differently for you guys. Now that we're down into the foot, and we have the fibula and the tibia kind of coming down here, then you have all sorts of foot and ankle anatomy. So you have the calcaneus, kind of this big one here. This one here is called the talus. They all have kind of Latin names, right? Navicular and cuboids and cuneiforms. So that's just some foot and ankle anatomy for you guys. And oftentimes patients don't know that if something is broken, then it's the same thing as it being fractured. So if your doctor tells you, or telling you a family member, like they have a fracture, then patients don't always understand that that just means that the bone's broken. So it could be a very severe fracture, or it could be not a severe, just but if anyone asks, broken is the same as fractured, and vice versa. All right, so we'll kind of wrap things up with some brain imaging. And this is an MRI of the brain. And again, the anatomy is labeled quite nicely here for us. I'll just go through, I'll talk you guys through it, and we'll finish up with 2 cases. So this is the frontal lobe, then this is the parietal lobe, and this is the occipital lobe. The cerebellum is down here, down here. This is kind of responsible for our balance and our gait and our walking. The corpus callosum, you may have heard, like, some people thought that Albert Einstein had a very large or prominent corpus callosum. Corpus callosum kind of connects the 2 sides of the brain. So this is the left and right hemisphere that it connects, if you can imagine. So this is kind of a slice, like kind of this way. The lateral ventricle sits here. It kind of circulates brain fluid, or like cerebrospinal fluid. The thalamus is here. The pituitary gland, kind of the master hormone gland. Midbrain pons and medulla, of course, very important. And then, yeah, you can even kind of make out the tongue here, and then the hard palate, and some of the sinuses here, like the sphenoid sinus, the frontal sinus. So same anatomy, just color differently for you guys. So frontal lobe, again, the kind of corpus over here. Cerebellum looks a little bit different from the rest of the body. And then midbrain pons and medulla. So, all right, so this case, so first thing you want to do is always, like, when you're looking at imaging, is like kind of orient yourself, like, what organ am I in and what type of imaging modality is this? So, so this is going to be a 45-year-old male, and the type of imaging that we have here is a CT scan of the head. So this is an axial cut, or kind of like transverse cut like this, if you can imagine. So this is the left side, and then this is the right side. This is the left side, and then this is the right side. So now we're kind of oriented. So what happened to this poor guy? So he has a history of head trauma. So hypothetically, let's say it's the winter here in Minnesota, and he slipped on ice and fell and hit his head. Of course, there are hundreds of other mechanisms of injury that could have happened. And of course, the arrows here are pointing at something. So this patient has head trauma. And the way we would describe this on imaging is that it's lens-shaped or lenticular-shaped. And this is in contrast to another type of bleed that we'll talk about, which is more crescent-shaped, where it kind of, you know, straddles the skull kind of more like this, where it's more like a crescent of the moon. So a lens would be kind of more like this, right? So this is more lenticular or lens-shaped. As you can tell, radiologists like to use fancy words to describe things. So much of our job, you know, just is describing what we see. This is a hyper-intense lesion, so it's basically more white. So hypo-intense would mean that it's more black. This is in the left frontal region of the brain. And we also see here that there's some sort of fracture. So this is also in the left of the brain here. So it's okay if you guys don't know what the differential for this might be. There's this is kind of an advanced topic, I would say, but you will undoubtedly learn about it in medical school. So.
Okay, yeah, so it's definitely a bit more tough because the audience, we have maybe internal bleeding or swelling, and I personally thought it was probably meningitis with like internal bleeding of that
Yeah,
sort.
those are all great thoughts, actually. This is an intracranial bleed, or a brain bleed of sorts. There's probably 3 or 4 main types that you'll learn about in medical school. This happens to be an epidural bleed. So this is an epidural hematoma. So a hematoma is a collection of blood. So hema for blood, oma for mass. So a collection of blood. And this is an epidural. There are other types of bleeds. Of course, this is a whole lecture topic on its own. There's epidural, there's subdural and subarachnoid, and then intraparenchymal bleeds. So don't worry about any of that stuff. The reason why this looks the way it looks, like lens-shaped in contrast to crescent-shaped, like I described earlier, is because this is epidural, so it's sitting on top of the dura, so epi. And the dura is different layers of the brain. So you have the dura, the pia, and the arachnoid. And so if you are subdural, if you're below the dura instead of on top of it, that's a subdural bleed or hemorrhage. And so that gives you more of a crescent shaped. So epidural is more lens shaped, subdural is more crescent shaped. And then subarachnoid, if you're below the arachnoid, then that looks different from, you know, all of these that we just described. And then other bleeds look different, of course, as well. This one also might be a little bit advanced, but this is going to be the last case, and then we'll kind of wrap things up and take some questions. So first things first, let's get oriented. So this is a MRI of the brain. So again, I'm showing you an MRI just to contrast it to a CT scan. So this is a CT scan. It looks a little bit fuzzier, right? MRI gives us a little bit more detail or resolution. Then of course the arrows are not going to be there if you're an actual radiologist, but for our sakes, they are pointing at something. So keep in mind this kind of a classic patient demographic and the complaints that I'm going to describe in just a moment. So this is a patient who is 40 years old and happens to be female and presenting with blurry vision for 2 weeks. She might also complain of diplopia or like seeing double, or her eyeglass prescription may have worsened and had to get stronger eyeglasses. Either way, something is going on with her vision. And the way we can describe this medically is called this optic neuritis. So this is kind of inflammation of the optic nerve. She might also complain about something like, you know, my balance is off, or I'm having difficulty walking. This can be called ataxia, is the medical word for that. So then if you get an MRI of the brain, then you might describe this, because after all, we're really good radiologists and we just describe things. And the way we describe things is that this would be periventricular. So kind of these lesions that we're seeing are near the ventricles. So remember, this is the lateral ventricle here. So peri means in and around. So it's periventricular. These are globular foci. So they're kind of globular, like little globules, like little circles, like not perfect circles, right? And then foci just means like a focus point, right? Like a lesion. So they're periventricular, globular foci. And anyone have a good differential for this? Might help more to focus on like blurry vision, difficulty walking in this kind of demographic.
Yeah, so this one's definitely the toughest out of all the cases today. The first thing that popped into my mind, probably either diabetes, which is I have no idea, that's like just a shot in the dark, or something with an inflamed oh, someone says tumor.
That's good. That's good. So this is a case of multiple sclerosis. So some of you guys may have heard of MS.
Yeah, someone actually just type that in right now.
Oh, perfect. Perfect. Yeah, that's great. So tumor is a great differential to have, because oftentimes if you have a mass sitting in the brain, it can press on certain parts of the brain and then cause some of these problems as well. It can cause blurry vision. It can cause ataxic gait or difficulty walking. So, but as far as, so multiple sclerosis is an autoimmune condition. And what you get is these plaques. So these are kind of the foci that I was talking about. These are the MS plaques that you get in the disease. And it's autoimmune. And so autoimmune conditions are generally more common in females, and MS happens to onset around 40 years of age. And this kind of optic neuritis or inflammation of the optic nerve is kind of a classic board style presentation. So you'll learn about this in medical school. So you guys are doing great. So I'll finish here by showing a super high resolution scan of, this is an MRI of a 58-year-old female. This is her brain. It was scanned after she passed away in the ICU from pneumonia. So her immune system was low from having chemotherapy for her leukemia. And so her brain was donated to research. And so researchers took the brain and then scanned it in an MRI scanner with a super strong magnet for over 100 hours. So they used an MRI scanner that had a 7 Tesla magnet. So 7 Tesla is just a huge, huge magnet. So the stronger the magnet, the more resolution that you can get with the images is the take-home point here. So in clinical practice, you typically have like, magnets that are like 3 Tesla or like 1.5 Tesla. So much less strong than this. But I thought this is just all neural normal neuroanatomy. So it's all normal brain. But I thought it was just really cool because it's going to be a really cool contribution to kind of medical research. It's just a beautiful image. So yeah, that's that. So if you're still interested in radiology, I'd encourage you to stay connected with all of these resources. So Ben White has a fantastic blog, not just about radiology, but about all sorts of other things. Feel free to screenshot this if you want, just to have it for later or in years down the line. So if you are a medical student and want to do radiology down the line, Amster has a fantastic guide in like matching into the specialty. If you are, pre-med or in high school, listening to this podcast, I think is a great idea because it'll expose you to so many different medical specialties. This guy does a fantastic job interviewing different attendings, and he does interview, I think, 3 radiologists, 2 of which happen to be interventional radiologists. This is more of a website designed for 3rd and 4th year medical students and residents. Of course, you could sign up for the newsletter now just to kind of get an idea about what issues people are talking about in the specialty. And then, of course, YouTube, Instagram, TikTok, Twitter, they're all fantastic places to be. I think generally the medical community is very positive, at least in my experience on kind of Instagram. TikTok is kind of a polarizing place sometimes. But here's some fantastic accounts that I think you should follow, in addition to mine, of course. So I'll end by saying that some people think that radiology is easy, but it's not all black and white. There is quite a lot of gray area, as we have seen. So that concludes my presentation. Let me know what questions you might have, what you found interesting, or what you learned. If you're watching this somewhere else, I don't know, do the whole like, comment, subscribe, share, comment below. I already told you guys to follow me, so do that. And yeah, feel free reaching out, connecting. I think what I enjoy the most about social media is just connecting with other people and lending some sort of helping hand. And it is my humble opinion that radiology truly is the best kept secret in medicine. I feel like not a lot of people know about it, but maybe after this, more people will know about it. So yeah, I hope you guys found this interesting.
Thank you so much, Dr. Parisis. So we do have time for one question over here that was sent earlier in the chat. So the question is, could you share your experience with the MCAT? If you have any suggestions or advice for our students over here, for our audience.
Yeah. So I took the MCAT in 2015 in January, and that was the last date before they switched into the new MCAT. So I took the MCAT with 3 sections, and it was 6 hours or 5 hours, however long it was. So the MCAT that you guys are taking is different. So I do have some tips, but I'll just preface it with that. So, so my first tip is to start with a foundation. So it all starts with like your undergrad, pre-med chemistry, organic chemistry courses, physics. Like it all starts with like getting a good foundation. So your MCAT starting actually starts when college starts, if you want to think about it that way. I know, sounds awful, and it is awful, but it will make your life easier if you learn this stuff earlier rather than later. Of course, if you learn it really well now, then you'll have to spend less time relearning it later. Either way, you have to learn it at some point. If you don't learn it early on, then you'll have to relearn it learn it eventually when you take the MCAT. So when you're actually spending time doing dedicated MCAT studying, you might do this for 1 month or for 3 months. I spent more around 3 months studying for the exam. And I took it twice, by the way, so don't feel discouraged, but I would try not to take it more than twice. If anything, you just want to have an upward trajectory in your score. So let's say you spend an average of, 2 months studying, and then you want to kind of gather a baseline of information and knowledge. So that can be with like books. You can just read the books all the way through and take notes. You can watch a bunch of videos. You can do both. You can listen to podcasts. There's so many different resources out there. And then after you start acquiring your knowledge, then you want to start applying it as fast as you can. So if you want to go, I'll drop it here in the comments. Go to usmleworld.com or uWorld, and they have a question bank that is probably, you know, from the kind of Reddit and YouTube research that I've done about the MCAT these days, it's like this is what the kids are using. This is the gold standard, I think, for what the question bank that everyone should be using should be. Of course, you can get like Kaplan or I don't know what else, but we use USMLE World in medical school, and they even have a question bank for I think PA students and for high school students with like the ACT and SAT. And I mean, wow, if I had UWorld like a question bank in high school, I mean, I probably would have crushed the SAT. But you know, I mean, I did fine. Like I did like I don't know, I guess above average, but I didn't like actually study for it. So if you really just you know pay for UWorld, it's worth every penny. And you know, do all of the questions all the way through. Do the practice questions, figure out what the right answers are and why they're right and why the wrong answers are wrong. Read the explanations, read the charts, the tables, the graphs, all the pictures and the diagrams, and you will learn so much from UWorld. So you want to start applying your knowledge as fast as possible, I think. And then if you're still like having a hard time kind of retaining everything, I think the third tip I have is to use flashcards. So you want to use this program, I'll leave it in the chat here, called Anki or Anki. You may have seen videos about it on YouTube. Everyone's talking about it. And I'm here to say that it revolutionized my studying in medical school. Like I remember really struggling with anatomy with like my very first course in med school. And then once I started doing Anki, it dramatically improved my scores. So yeah, I would say basically start with the foundation, build a strong foundation, then start doing like practice questions and apply yourself. And then you want to do Anki to kind of supplement your weaknesses, basically, like what things am I forgetting, basically, to really like hammer those and like drive them home. And then towards the end of your studying, you'll do exactly what everyone else does, which is basically take a bunch of full-length practice exams that the AAMC puts out, which is maybe they have 2 or 4 of them. I don't know how many they have, but yeah, that's those are my tips.
Okay, and do you have any general tips for undergrads, for pre-med undergrads, you know, going or at least preparing for medical school in terms of extracurriculars and such?
Yeah, I find questions like these difficult. I get asked questions like these a lot. And I guess I'd like the person asking to just be more specific with their question, because I could give you a bunch of generic advice, but I don't know that that would help either you or me or anyone else. So extracurriculars, I mean, you guys kind of know like what you need to do, right? So we all kind of do different things to satisfy the same requirements, I think. So I could share a lot of my extracurriculars, sure, but you want to do things that are unique to you. Like what you are passionate about is likely different from what I'm passionate about, and vice versa. And you just want you want your like who you are as a person, your identity to kind of jump off the page. So on like the application, right? So I could tell you like, you know, be a rugby player and play traditional Greek folk music, but who is that helpful to? Like it might be helpful to someone who's similar to me, but odds are we're all very different. So I posted about some of my hobbies and extracurriculars on my Instagram page. So I'd highly encourage you to check out some of those kind of mini blogs or mini blurbs where I'm kind of a little bit more reflective and introspective, because that might be more valuable to you, rather than me like telling you these are the 10 or 15 or 20 things that I did as a pre-med. I mean, that can feel almost, it can be a little overwhelming to hear about a million accolades that someone has, or like I got all these scholarships and awards. I mean, you know, I don't want to sit here and humble brag either, and I don't want anyone else to feel bad. So that's what I'll say.
It's fine. It's fine. Thank you so much for sharing your experience with us. I will be sharing our wrap-up presentation as we are ready. As we are getting ready to wrap up. Once again, thank you so much for joining us today, Dr. Parisis. And I do think we all learned a lot from this presentation. I know that's most of our audience was writing in the chat. They did enjoy it very much. And I also did enjoy the memes a lot. So thanks for that. It was really engaging. So considering this, I would like to encourage you all to reflect on this session today with these 2 questions that we have on screen. What brought you to the session today? What are 3 major takeaways you got from it? and what do you want to learn more about? You can definitely just answer these on your mind or write them up and answer them. And if you do answer these questions or a reflection, even though it is not required, we encourage you all to submit it to our website for publication for recognition of your hard work and to enhance your future applications. I would also like to mention once again that Pre-Health Shadowing is launching a research program that will allow students to connect with principal investigators as they conduct research in a variety of topics, fields, and locations. This program, I want to highlight once again, is 100% remote, which means you have the power to connect with absolutely anyone. For more information, you can fill out the interest form that was sent in the chat. And we will get back to you as soon as possible with any additional details we may have. If you want to learn more about pre-health shadowing and how to get involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic design, and social media promotion. And we are also accepting team member applications if you want to take on a more active role in PHS to lead projects and initiatives to be up here with us. Once again, we are humbly asking that if you are financially able, that you please consider donating to us. It costs a lot to keep our program up and running and free to all of you. So if you are someone who can afford to, or if you know someone else who can, please support those who cannot by donating to our organization so everyone can continue to get the education they deserve. Otherwise, we simply ask you spread the word about pre-health shadowing to reach as many students as possible. And now for the part you have all been waiting for, that is earning your digital certificate. So the first thing you're gonna do is go onto our website and visit our professionals course pages. In this case, you're gonna visit Dr. Parisis' page. There you will be able to take our quick 10-question multiple choice quiz based on the content from the session today. You have 30 minutes to earn a 70% or higher to get your certificate. And we do know that sometimes technology can be difficult. So for this reason, we allow up to 2 attempts to take the assessment. But if you run into any other difficulties, do not hesitate to contact us. We are more than willing to help all of you guys. And we do recommend waiting about 30 minutes to an hour after the session to take the quiz, just so the website does not crash from a high influx of students. And I do want to highlight that the quiz will be open indefinitely, so you can access it anytime you want. And finally, once you have passed, you can click the Finish Course button at the bottom of the professionals page, and there you will be able to download your certificate verifying your virtual shadowing hours. If unfortunately you missed a part of this session, or you want to go back and view other sessions to earn more certificates with verified virtual shadowing hours, you can go to our YouTube channel and watch our previous recordings. You can also find them via the professional pages on our website and take the post-shadowing assessments for these as well. Be sure to follow us on social media or subscribe to our email list for the latest updates on upcoming sessions and events. We are currently booked for the rest of June for virtual shadowing sessions, and well, we definitely hope to see you guys over there. Once again, thank you all for joining us today, and please do stick around if you have any questions, and myself and other team members will definitely be happy to answer any of them. The shadowing session is officially over, and I invite you all to log off. Have a wonderful day, evening, or night, depending on where you are.